The increasing price of healthcare is largely due to patients with chronic illness. Minority senior citizens are a growing segment of the Medicare population, and now policy discussions are revolving around addressing the needs of those who are chronically ill. This morning, we will talk to two experts who are leading the conversation on optimizing care for the chronically ill, especially those who are lower income. First, we have ChenMed CEO, Dr. Christopher Chen, who leads the field on implementing value-based care to improve primary care of the neediest populations. Dr. Chen is with us via Skype from Miami. How are you, Dr. Chen?
Morning, I'm doing very well here.
Well, we really appreciate you joining us, and I would like to dig right into it. Tell me how ChenMed is transforming care for low-income patients at this time.
Well, we're all aware that healthcare is broken. It just is particularly broken in certain populations. You know, in New Orleans, where we have medical centers, you'll find that there's a zip code where the average life expectancy is in the lower to mid 80s. In that exact same city, just a few miles away, there's actually a zip code in which the average life expectancy is in the upper 50s to lower 60s, and we're talking about a 20 to 30 year difference in life expectancy. In a country where we're proud of our equality and social justice. What we've also discovered is in that same population where there's a tremendous amount of illness, we'll find a population of the old, the poor, and the sick. And it's that same population that we believe accounts for the majority of healthcare costs in those communities. In any given community, you have 5% accounting for roughly 50% of the healthcare costs. And so ChenMed discovered that there was this major disparity, that there was this challenge in terms of the minority accounting for the majority of costs. And so we decided to build comprehensive advanced primary care medical centers directly inside of those neighborhoods. And their goal is to primarily prevent catastrophic hospitalizations for this population. We accomplish. Go ahead.
No, that variance is really high. I want to let you finish your point, though, about catastrophic hospitalizations, because I think it really relates to price. So please expand on that more.
Well, you know, we have a system today that is, you know, highly incentivized for sickness as opposed to prevention. And so what we've discovered is that, you know, there in this population, I'll give you an example of heart failure. We believe that much of a heart failure in terms of the admissions are preventable. And so in this population, we need to have a much more hands-on approach, because whatever challenges that they may have in terms of their healthcare illnesses and chronic disease, it's only amplified by the overwhelming amount of complex problems that they face other than their healthcare. An example of that would be transportation, literacy, access to good food. And so if you're trying to prevent hospitalizations, what you need is a completely different system that isn't incentivized by volume, isn't incentivized by sickness, and doesn't work off a traditional billing environment. I'll give you an example. If you have a patient who consistently is going to the hospital because of they keep falling. Well, you know, you can't create a bill to go into a patient's house and help that patient and look for rugs where they can trip and where they can fall. Another example is you have a patient who continues to get admitted for heart failure. I remember as a practicing cardiologist that patients keep coming to the emergency room, the same medical problem over and over again, and the emergency rooms were so happy to treat them. Those admissions cost $20,000 to $30,000 each. But if I could sit with a patient and spend time with them and talk about their diet and help them overcome some of these dietary challenges and substantially improve their adherence and compliance to certain medications, and where there's not a bill for that either, I can substantially reduce heart failure admissions, in some cases greater than 50%. And so what we do is that very hands-on, hands-on and sort of customized approach to a population in which they have just an overwhelming amount of complexities is what is needed.
Right.
And
so
that
tell
can't be accomplished in a fee-for-service environment.
So, Doctor, tell us how value-based care is transforming primary care of these needy populations, because that really is where the crux of this matter falls, right?
Sure. So if the goal is to try to improve the quality of the care and to reduce costs, you have to go after this 5% of the population, the old, the poor, and the sick. You have to go after them. And the way you have to manage their problems is you need a prepayment process, because you don't have a one-size-fits-all for every person in this population. It's a challenging population. And so some of our patients, they require transportation. They just can't get to a doctor to see them. Some of our patients need to be seen much more frequently. On average, we will see our patients, we target once a month. In some cases, for our most sick patients, we see them every week. There are patients that we need to go to their home and help them with some of their challenges. We have patients where their Social Security check is being stolen by somebody in the house. That is a very customized problem that we have to manage for these patients. And so the typical primary care doctor will take care of 2,300 patients. In our populations in our neighborhoods, the typical primary care doctor will take care of 3,000 patients.
Wow.
But for ChenMed, for this 5%, 5 to 10% of the population, our doctors will take care of just 400 patients, create a customized approach towards their care, and they'll be incentivized for substantially reducing catastrophic admissions that are preventable. And in order to do that, you have to have a prepayment process. You cannot find a bill for every little intervention that you want to go after to substantially improve the outcome. And that's
that
what
makes sense. Right. So how are you expanding language access? Because that's also a barrier for many of these people, right?
Absolutely. So there's two types of literacy access. There's the language access. There's also healthcare literacy as well. And there's actually illiteracy that we're challenged with. The first thing is, if you have any kind of barrier to communication, you must overcome it. You cannot have a bill that says if they speak Spanish, we need to bring in a special person for that, and therefore you need to solve for that. So the value-based care environment says you need to meet that patient, and you need to meet that need in whatever it takes to substantially improve their health. So that way they're not showing up in the emergency room every other week. And many times it could just be, hey, that doctor, you need to be able to communicate. That team that takes care of that patient has to be able to communicate with that patient, whether they speak Polish or Creole, or in South Florida, for example, we have a lot of Spanish-speaking patients, and they do not speak English. And so if we do not meet their need, they will go to the emergency room every other week to meet that need. And they will show up with their preventable catastrophic illnesses. And so we are therefore incentivized to solve that problem.
Absolutely.
In some cases, it's not just healthcare literacy, it's technological literacy. Remember, the majority of healthcare systems out there are not built for this population. They're built for the typical Fitbit wearing, Peloton riding, has access to internet, and they can search the web and make an appointment. What happens if you don't have Wi-Fi in your house? What happens if you don't know how to use a computer? And so these customized approaches to trying to manage these most complex populations can only occur in a value-based environment. And if we're talking about cost, you've got to figure out a solution for this 5 to 10% of the population, in which is not the Fitbit wearing, Peloton riding population that the majority of healthcare is built for.
Well, thank you so much for joining us, Doctor. We really appreciate your insight.
Thank you so much.
I'm joined now by another leading voice who's bringing Medicare to underserved communities, Dr. Gary Puckrein. He's the president and CEO of the National Minority Quality Forum. His work focuses on helping communities and policymakers prevent premature death and preventable illnesses in special populations. Thank you so much for being with me, Doctor.
Thank you. Good morning.
So, good morning. Minority senior citizens right now, they're the growing segment of the Medicare population, and they have some unique challenges and opportunities in this patient constituency. Can you outline that for the audience?
Sure. I think one of the most important things for people to understand is really about the Medicare program itself. So when President Johnson started the Medicare program, it was really designed to help families who had seniors in their family, and the cost of their health care was bankrupting families. And so the whole idea behind Medicare was to support those families and keep them from going into bankruptcy. Fast forward into the 21st century, our sense is that Medicare really needs to be reformed. It needs to be envisioned for the 21st century. And really what we're talking about is how do we conserve high quality, long lives? And right now the Medicare program, if you talk to most people who talk about Medicare, are talking about cost and value and not lives and the investment that we need to make in preserving high quality lives. Added to that is when you look at the underserved community, where Medicare out-of-pocket costs. So every time a beneficiary hits the Medicare system, be it for the hospital, the emergency room, the physician's office, they pay 20%. And on average, a Medicare beneficiary could be paying over $3,000 a year just on out-of-pocket cost. And that doesn't even touch the premiums for Part D drugs. So by the time you throw in the premiums, you're talking about $5,000 a year on households where people are on fixed incomes. That gets to be a lot of money, and it shows up in the quality of care and their ability to access care. We think that the program really needs to be reimagined for the 21st century. And really what we need to be focused on is how do we help people live long, high quality lives and make that investment in those populations, which is really not the conversation that is going on today.
So, Doctor, talk about how expanding language access is a big part of this.
It's all part of the same. It's all part of the same issue. America is browning. It's changing. The population that we had when Medicare got started in the 1960s is a very different America, and so part of what we have to do is meet this emerging marketplace, really. That's what's happening in healthcare. We have this emerging marketplace. It's diverse. Its need for healthcare are different. It is not just access, language access. It's also access to appropriate medications. It's also access to high quality specialists and providers. And so the whole program itself needs to be re-looked at for the 21st century.
What does it take to re-look at a program like this? Is it the CMS? Is it the U.S. Congress? Where can the change actually happen?
So part of it, obviously, the fiduciary agent here is Congress, right? They have the fiduciary responsibility, and when you go
financial responsibility for the audience.
Yeah. Sorry.
Yeah.
But the point is that they're the ones who have to set the ground rules. When you look at some of these members' districts, inside their district, you have people who life expectancy from birth is 60 years old, right? So many of them not even getting into the Medicare program. And once they get into the Medicare program, they're facing all of these disadvantages. So it really starts with the member of Congress. They have to set the agenda for what is going on in the program.
Yeah, so there are all these policy initiatives, trending efforts in Medicare to address the needs of low-income and minority patients. Are you heartened by what you see?
No, because I think they're still thinking about the program as if it was in the 20th century. And the reason why I'm saying that is we now are operating at the genome level. Our science is taking us to a place where we've taken HIV, which was a deadly disease, and turned it into a chronic disease. If you look at cardiovascular disease, they're on the decline. We have the ability to actually intervene and save lives, but the conversation is really on just money, and I think that's the wrong place to start. We have to start with how do we conserve lives, because what we don't want is the next generation to face the same problems that this generation.
Well, and one of the major points that I've heard throughout this series is that saving lives actually saves money. Is that by stopping catastrophic illness and going to the emergency room, by improving quality of care, you will save significant sums overall, because delivering that emergency care is much more expensive than delivering preventative care.
I don't want to take your audience too deep into the mire here, but the point is that's not the way the system is presently constructed.
Right.
The way the system is presently constructed, keeping people alive is an expensive proposition, and so do we want to make that investment? And even more importantly, shorthand for what you're saying is we want a well care system. We want a system that keeps people healthy rather as a sick care system. That's a deep transition. We haven't yet started to pay for wellness and well-being, and I think that's really the conversation. As we move deeper into the 21st century, we have to be able to manage diseases like diabetes and cardiovascular disease essentially what I'm saying to you is that we have to be able to control health outcomes in our community, and we have the capacity to do that.
So final question for you. Why haven't we, like you said, we not cured HIV, but we significantly changed the trajectory of HIV in 20 years. Diabetes has been around for a lot longer than that.
But
why hasn't that changed?
The reason is that our elected officials are like old generals. They're fighting the war in the 20th century, and they haven't really built themselves for the war in the 21st century. We need new leadership. We need a different kind of conversation, and that's not what we're getting. Everyone is focused on expense, but they're not looking at it as infrastructure building, that we're actually building something so that we can build high-quality, sustained lives, and that's really the purpose that Medicare should be looking at.
Well, thank you so much for joining me, Doctor.
My pleasure.
We really appreciate it.
Thank you.
Tomorrow, as we continue our series here on Rising on the Future of Medicare, Dr. Jerry Penso, President and the Chief Executive of AMGA, a healthcare advocacy group, will join us to talk about how corporate America is preparing for the Medicare of the future.